Hello friends, continuing the previous session of heart diseases in pregnancy. This is part 2 of this session of heart diseases. Here we'll discuss some more facts about heart diseases, but in the previous video we have discussed about the diagnosis of heart disease in pregnancy, how to diagnose that signs, symptoms, ECG findings, and all the abnormalities, increased JVP and systolic diastolic with thrill S4 sound can be observed here, and the chest x-ray will show marked cardiomegaly, any type of arrhythmias. It all has been discussed in the previous video. Okay, and the most common things and Clark's classification, pregnancy where it is contraindicated, all the points where it is contraindicated, when the MTP is done in the heart disease patient, NYHA classification, and the management, how to manage the heart disease patient in pregnancy, and indications of cesarean section in heart disease patient, and anesthesia which should be used. So it will be epidural anesthesia should be used, and I prefer the most. But there are some conditions where general anesthesia is used. I have discussed all the things in the previous lecture. Now we'll continue our session with management of third stage of labor. So third stage of labor is a stage in which we are mainly focused on removal of placenta. After the delivery of baby, now our main target is to deliver placenta. So here in the third stage we will deliver placenta, and active management of the third stage of labor is important in the heart disease patient, because in the active management you will you will excite the uterus so that it will lead to early separation of placenta and also produces uterine contractions following its separation. So active management is essential. Active management of the third stage of labor is important to facilitate the third stage. It will minimize the blood loss in the third stage. So its advantage that it will minimize blood loss. Okay, it will minimize blood loss to approximately 1/5 of the normal, and to shorten the duration of the third stage of labor, it is also important to shorten the duration, and also reduces the maternal anemia. And the second one, give injection diuretic. But before this, methyl ergometrine is contraindicated in the third stage, because it will produces a tetanic contraction, so it is avoided in these heart diseases pregnant female. And give injection diuretics, which is contraindicated in hypertrophic cardiomyopathy, mainly the injection diuretic and the vasodilators. So diuretic and vasodilators both are avoided in this HOCM, hypertrophic cardiomyopathy. And also injection diuretic is generally avoided. You should avoid this injection in any heart disease patient. You should avoid. Okay. And the antibiotic prophylaxis for infective endocarditis is generally not needed now. And the next thing, that the women with the highest risk of infective endocarditis, so prophylactic antibiotics for bacterial endocarditis, it should be preferred in some conditions, like mainly the cyanotic congenital heart disease, or the prosthetic heart valves, or prior history of infective endocarditis, cardiac transplant. So the prosthetic heart valves, cardiac transplant, prior history of infective endocarditis, cyanotic congenital heart disease, hypertrophic cardiomyopathy, any dental and respiratory tract infections if present, the rheumatic heart disease, and the dose and the drug which is given to prevent this is IV intravenous ampicillin. It's intravenous ampicillin. Okay, 2 grams plus gentamicin. It's a gentamicin which is given 1.5 mg per kg. Okay, and it is given not to, it should not exceed 80 mg and given at the onset of induction of labor, followed by repeated doses 8 hourly. So every 8 hourly you should repeat dose, and it is given at the onset of labor or induction of labor. So this is the for the prophylaxis, antibiotic prophylaxis during labor and 48 hours after delivery is considered appropriate for infective endocarditis. Now the anticoagulant of choice in pregnancy. Anticoagulants generally in pregnancy given are warfarin and heparin. Warfarin is a strong anticoagulant and heparin is a weaker anticoagulant. But warfarin is having a disadvantage. It crosses placenta and affect the fetus. It crosses placenta and affect fetus, causes chondrodysplasia puncta, which is some fetal limb abnormalities, and also bone stippling, mental retardation, and nasal hypoplasia. So considering this, warfarin teratogenicity, warfarin teratogenicity, okay, it causes nasal hypoplasia. It's nasal hypoplasia, saddle nose mainly, smaller nose, the bones will be small of the nose, and bone stippling, and a mental retardation. Okay, it's mental retardation, and the feto-maternal hemorrhage. These are the fetal warfarin syndrome, you can say this. And if warfarin affect the fetus like this, and mainly the term chondrodysplasia puncta, remember this term. Okay, so the next thing, again, the heparin does not clot placenta and does not lead to any congenital malformations. So generally preferred mostly in the during pregnancy, but it is a weak anticoagulant. It's not only a disadvantage of this, but it is also a good thing and advantage. We are getting advantage of this, that it is a weak anticoagulant. Now, low molecular weight heparin and difference between unfractionated heparin. Low molecular is given subcutaneously and unfractionated is given IV route. So remember, U is given V. U is given through V route, and low molecular weight heparin is given subcutaneously. Low molecular weight heparin is having a longer duration of action, and unfractionated is a shorter duration of action. For a longer duration, for a low molecular weight heparin, you should monitor factor 10th A, which should be 0.8 to 1.2 international unit per ml 4 to 6 hours after low molecular weight heparin administer. Okay, and the APTT target 2 times of control is to be monitored during unfractionated heparin. And the disadvantage mainly with this is it causes IV line infection risk, osteoporosis, and heparin induced thrombocytes. So IV line infections, osteoporosis, and heparin induced thrombocytes. And the next thing, now the choice of anticoagulant according to the period of pregnancy. So up to 12 weeks, the low molecular weight heparin is preferred because it is a period of organogenesis, when the organs are formed, when the bones are mainly formed. And a second choice here is warfarin, but in the dose less than 5 mg per day. The period of organogenesis is very important to know that beside low molecular weight heparin, warfarin can be given, but in the low dose. Our first choice will be low molecular weight heparin. Then in between the 12 to 36 weeks, we can prefer warfarin, as it is a stronger anticoagulant, and it should be there. And in the 36-week beyond, as it is near the term, warfarin should be stopped, and again the low molecular weight heparin should be started, because if the warfarin is now continued for a longer, it can lead to PPH, postpartum hemorrhage. So warfarin should be stopped, and will prefer low molecular weight heparin. Now the 3 days before or 1 week before delivery, so 3 day or 1 week before delivery, we should give unfractionated heparin, because it is a shorter it has a has shorter duration of action, so will get benefit in that term, that anticoagulants will be stopped, no more bleeding, no more pph. So unfractionated, we should switch to unfractionated heparin near more term, okay, like 3 days before or 1 week before, and on the day of the delivery or 6 hours after we can restart, but on the day of delivery all the anticoagulants should be stopped. Stop all the anticoagulants. But after 6 hours after vaginal and 24 hours after cesarean section, one can restart with any low molecular weight or unfractionated heparin or warfarin. We can start anything. Okay, and warfarin is not contraindicated during breastfeeding. So just remember this important point, that during breastfeeding, the warfarin is not contraindicated. Warfarin is not contraindicated. Okay. Now we can restart like low molecular weight heparin, and unfractionated can be given for 4 to 5 days, and then we can switch over to warfarin. You can proceed like this also. And what if the patient come to me at 36 weeks and is on warfarin? Then we should give the patient, we should not stop the warfarin now. We should just go for a cesarean delivery. We stop warfarin now and we'll start, but with a low molecular weight heparin, but will not proceed for vaginal delivery, will go for cesarean section. Okay, and the next thing, now the contraception of choice. Contraception of choice can be temporary methods or permanent method. Now the temporary methods earlier which is used are the barrier methods, mainly barrier methods, which includes condoms or diaphragms or jellies, foams, barrier methods. Okay, and now it is used. Intrauterine contraceptive devices are mainly preferred, copper T mainly, and permanent methods will include vasectomy. But if the man refuses, if the partner refuses that he will not undergo this, then we'll prefer tubectomy. And tubectomy, the best method which is preferred is mini laparotomy, in which we will give a smaller incision just below to umbilicus and under umbilicus, and done under local anesthesia. And the best time for this is after 6 weeks of delivery, or second best time is end of first week after delivery. So the best time will be 6 weeks after delivery, and the second best is end of first week after delivery. Laparoscopic sterilization method is contraindicated. Note this, that laparoscopic sterilization method is contraindicated. Now thank you so much for watching the video.